lupus and these other doctors because the lumbar puncture is abnormal. You get all these symptoms, right?
Yeah.
You shouldn't see the lymphocytes in the spinal fluid with fibromyalgia. You shouldn't see the elevated SED rate. So there are some lesions in the brain. MRA, which looks at the vessels, irregularities. Now, you do have this oligoclonal band, which is a abnormal antibody that was noted, positive.
Yeah.
So that can be seen sometimes with lupus affecting the brain too. Okay, decreased perfusion in one of the blood vessels there. The Rituxan, this this study that I showed you, this has 10 patients that has 10 patients that had brain involvement from lupus, and they all showed some amount of improvement with Rituxan. So that's a possibility. But this is, the Rituxan takes about 5 hours, 4 or 5 hours, and then you'll receive it one time, and then 2 weeks later you'll get your second infusion. It's a type of infection in the brain that could occur. Did they talk to you about that too? That's a brain infection, and that's untreatable if you get it. So there have been a handful of patients with lupus, and thousands of patients have been getting Rituxan. A handful of patients had developed this PM.
Yeah, well, this is the sad story of a chronic disease, and chronic immunologic disorders have this propensity to what I would say, the term wouldn't be to mutate as so much as the markers that we try to diagnose them tend to overlap. So example, when they talk about the antiphospholipid antibody syndrome, they define it very specifically to make that diagnosis. But there are many things that overlap with it. So example, it can be what's called primary, which means all you have is the antiphospholipid, or secondary. Secondary is most often associated with true lupus. But it can overlap with other mixed connective tissue disease, a whole slew of rheumatologic disorders. So none of them kind of fall into a perfect circle. So you might have lupus, you might have antiphospholipid antibody syndrome, you might have mixed connective tissue disease, you might here have rheumatoid arthritis, you might have Sjogren's syndrome, okay? And on top of this, there are other things. Example, over here you can have immune thrombocytopenia, ITP, low platelets. Okay? In fact, 16% of these patients have this disease. About 30% of patients have lupus. So there's a central doctor, and he's the clearinghouse, because he's the one who's going to know what every medicine is on, why it's being given, what are the markers that you follow. You can see the other doctors and follow up, but everything should flow through one doctor. And the reason is that gets rid of the confusion. There's a problem, lupus anticoagulant. The studies for what's called the lupus anticoagulant, that's the strongest marker for the so-called antiphospholipid antibody syndrome, associated with the highest risk of events. But you did have what's called an anti-beta-2 glycoprotein antibody that was an elevated IgM, okay, and it's hard to judge what that really means overall, but it is a marker that goes with the antiphospholipid antibody syndrome, not as potent as the lupus anticoagulant, and not really predicting any. We did a test called a D-dimer test, which looks at your activation of clotting, okay, and it was in the normal range. And it's interesting that you have what's called a high IgM, which is released by the acute activation of the immune system of the newer cells. And that drops very rapidly with Rituxan, because it kills the cells that make that. Probably we should get you to see, if there's a lesion, get you to see if we can get you in there, Leslie Weiner. who is the former chief neurologist here, one of the world's experts in multiple sclerosis and other things, probably one of the world's best neurologists. All right, so this is a long day. I told you it's a long day because they always do this really slow infusion. Okay. So he felt that you had a pattern that was obviously consistent with autoimmune disease. Well, I mean, the simple reason is that the disorder you have, which is mediated through probably antibody and T lymphocyte interactions, that when you deplete your B lymphocytes, you also reset the T cells. So you actually inhibit both arms of the immune system that would be involved in your neurologic defect. We've seen that in other autoimmune diseases, such as immune thrombocytopenia. My friend Roberto Stassi showed that. We've seen that in neuromyelitis optica, which is another neurologic variant of multiple sclerosis. In fact, Rituxan becomes the drug of treatment. And we've seen it in some cases of lupus cerebritis. So I think, you know, all in all, in view of your history and having been assessed by, I think, one of the best neuroimmunologists in the world, you know, Les Weiner, one of the big experts in multiple sclerosis, I think it's probably the best approach to maintaining you. And so I think I think we'll see.
So the reason I'm seeing you is that they want to think about putting you on Rituxan. And the person who gives Rituxan, our hematologist, and Dr. Shineda want to be sure because of the fact that lupus is an indication for Rituxan. Now, Sjogren's comes all by itself, okay? And then Sjogren's comes as a secondary phenomenon. Your blood tests would suggest that it's secondary. Okay. And the primary in that case is usually SLE. Okay. So we think you have SLE with a secondary Sjogren's. Okay. And that we're basing on your antibody studies in your blood. Okay. He agrees with the diagnosis, and the rheumatologists agree. Yeah. So we're treating her with Rituxan, which is, you know, anti-CD20, it's a B-cell problem. Yeah. All right. So I think the big issue is to try to get it in South Africa. Okay. You're going to have all our records, and we'll try to make the point that this is this looks like a B-cell problem, and this is the best thing. We would like you to get this every 6 months. Yeah. So she was given, we made the diagnosis of Sjogren's on her. Okay. So she has some white matter lesions, which do not look like MS. She has systemic findings. She has a Sherma test that's positive in terms of tears, which Dr. Seydoun confirmed. Yeah. Well, you need to have this at least for a couple of years, and then you see. And we usually stop and see how the patient's doing, because there is a long-lasting effect for it. Okay. Yeah.
So Ms. Finger has varied complaints that we think are best explained by a neuroimmunologic disease. We're calling this Sjogren's disease, but we believe Sjogren's is secondary to another collagen vascular disease, namely lupus in this case. So the therapy for this acts on B cells. Rituximab or Rituxan is the therapy that she's received and that she will continue to receive every 6 months for the next year to 2 to try to prevent her disease process from continuing and keep her symptoms stable and potentially give her a chance to improve. Unfortunately, from our talking about your history, your disease process has continued, so the symptoms have continued to accumulate or worsen over time, despite the other therapies, which did include IVIG. Our hope is that this therapy will make an impact on that disease process.